Welcome to the EuroPCR 2018 PCR TV program. Today, we want to introduce some interesting topic, bicuspid. I'm Dr. Chen from China. Joining us today is a very well-known expert in this field, Ron, and from Israel. And welcome, Ron.
Thank you very much, Dr. Chen.
As we know, the bicuspid is not a real clinical situation. Yes, person in some special country and regions like China. In our countries, we have the TAAV procedure. About half patients are bicuspid. So the first question to Ron, what is the challenge of TAAV to bicuspid patients?
Yeah. We have to appreciate that bicuspid aortic stenosis is a congenital disease and which over the years can develop stenotic and calcification and severe pathology of the valve. And this poses a special challenge which is, I believe, far and beyond compared to the conventional tri-leaflet aortic stenosis, which is by itself a big challenge. Now, if we think about TAAV, transcatheter aortic valve implantation, the use of catheter-based valve was traditionally associated with less favorable outcomes compared to the tri-leaflet aortic stenosis. This has been the case with the first generation device. But over the years, results have improved, but still we have a lot of challenges to overcome in order to optimize the results of the TAAV procedures among patients with bicuspid valves.
So from the aortic complex, aortic arch complex, do you think the bicuspid have some special anatomic characteristics compared to the tri-leaflet aortic wall?
Definitely. First of all, bicuspid aortic valves are heterogeneous. There are different pathologies, so they are not all the same. Second, there is a lot of asymmetry and deformation of the anatomy. So in order to adjust and well suit the valve into the anatomy, it demands far and beyond compared to the tri-leaflet pathology. And also, it is very often associated with aortopathy. So it's not just that the valve is diseased, also the aortic root is diseased. So it's a dual challenge confronted by the interventional cardiologist. So I would say it might be less challenge for the surgeon, but more challenge for the interventional cardiologist.
How about the classification and the classification, severity and distribution? There are some difference between tricuspid and the bicuspid.
Yeah, calcification can be truly proliferative, diffuse, and excessive among patients with bicuspid aortic stenosis. And this obviously creates a tremendous hurdle in order to optimize the results that can be achieved using the TAAV approach. So a lot of calcification increase the risk of suboptimal results, increase the risk of paravalvular leak, and also increase the risk of annular rupture, coronary occlusion, and also enhance risk for pacemaker implantation following the procedure.
Back to the TAAV procedure, we know the first generation have a good performance in tricuspid patients. How about the results, clinical results of TAAV procedure, the first generation device to bicuspid patients?
Yeah. The good news that we have made a huge progress over the last few years in terms of optimizing the procedural outcome. Also, procedural planning assisted and guided by CT has improved tremendously the ability to well adjust with contemporary valve into the bicuspid anatomy. There is no question that second or even I would say third generation device provides much better outcome, clinical outcome and procedural outcome with less complication compared to what we were able to report in the past.
Do you think as you have mentioned, the second generation have a better performance compared to the first generation device? Do you think it's a prime time for TAAV for bicuspid patients? Do we need some other specialized technique or device to this kind of patients?
I think we're certainly expanding our experience using TAAV among patients with bicuspid aortic stenosis. Nevertheless, we have to acknowledge the fact that as we expand the indication to younger patients, we are going to treat more and more patients with bicuspid aortic stenosis. And I'm not sure that all patients will be suitable for the percutaneous valve technique. So I think that at the end of the day, even in the future, there are going to be patients that would still be treated using surgical aortic valve replacement, and some other patients would be treated using percutaneous valve. The wisdom would be to really make a firm and wise decision who are the patients who can be treated using the catheter-based approach versus those that should be treated using surgery.
Mm-hmm. So many experts in this field talking about the future of the TAAV procedure in bicuspid patients. And some experts raise the dedicated device for this patient anatomic characteristic. What is the dedicated device for bicuspid patient? What is the real definition of dedicated device?
The dedicated devices are those devices that are best suited or even a priori designed to treat bicuspid aortic pathology. Right now, there are no real dedicated device. There are devices that were designed for tri-leaflet aortic stenosis that have been used quite extensively nowadays in bicuspid aortic stenosis scenario. And as I mentioned, this poses a lot of challenges on the one hand, but we have made a lot of progress as shown even during the meeting, that results are getting much better compared to the past.
Mm-hmm. If we want to design a dedicated device, what is in your mind, what is the key elements we should solve, we should count on?
So we have to deal with the basic pathology. We have to deal with the asymmetry, with the potential deformation, with the excessive calcification, and with the orthopathy. So one has to think about all these elements if we really want to design a valve that would be fully dedicated for bicuspid aortic stenosis.
And how about the annular or supraannular, in addition the orthopathy, and how to make a patient design for annular or supraannular?
Yeah, I think that at current stage, there are probably some options. I'm not sure whether it should be strictly annular or supraannular, as I'm not sure whether it should be balloon expandable or self-expandable. I think all options should be explored, And obviously, the valve that would show the best result would be those that would be used in the future.
So, just according you have said, it's not the prime time for TAAV in bicuspid patients. We need something to do in the future to improve the device, to improve our knowledge about the bicuspid patient. That's right.
Maybe it's not the prime time, but I hope we are getting there.
Thank you very much.
Thank you.